Welcome to the case number 1 of clinical problem solving in dentistry. Today we will discuss an interesting case that how with some innovative idea we manage this case. Before I begin, this is the disclaimer that this video is intended purely for educational discussion among dental professionals and students, and it does not constitute medical or dental advice, and there is no conflict of interest. Now, case context and brief history. The patient is 28 years male who presents with retained root, which you can see here, and retained root in 1-4 region, and there is also a retained root in 2-6 region, and 1-5 is pexapate. The demand for aesthetic in this patient is very high, and the patient wants a fixed restorations because he is going to get married soon. Now this is the interval picture which shows clearly that these patients need some aesthetic correction so that he can smile confidently during his wedding ceremony, and this was the main concern of this patient. Now the interesting thing is the intraoral picture, intraoral radiograph. In this radiograph you see the OPG X-ray and the IOP X-ray. In the IOP X-ray we can clearly see the root of 1-5, which is a wide sepate V sepate structure which is malformed. In the OPG X-ray also we can see the root is malformed and crown is also not well defined, and it is not good from the aesthetic angle. Now what is the problem? The main problem of this patient is the retained root is 1-4, compromised crown morphology in 1-5, and it needs some aesthetic correction in the premolar region, and he needs a fixed solution. That means a fixed types of restorations, and there is also some time concern so that he can attend his wedding. Now let's summarize the diagnostic summary. There is a localized dental problem involving maxillary left premolar region. It needs a aesthetic driven treatment plan. Occlusion is within normal limits, and there is no parafunctional habits. Now what is the learning objective of this case? The main learning objective of this case is that treatment plan to be customized to this patient with highlighting the aesthetic need of these patients. What are the different fixed restorative options in this case, and to appreciate the influence of decision making, keeping in mind the demand of the patient as well as the clinical prudence. Now let's see that what are the things that we should consider, that what are the key clinical and patient related problems that need to be addressed here, what types of fixed restorations can be considered, and which factor influence the treatment options that we will consider. Now what are the various treatment options? You see there are practically 3 treatment options for these patients. Number 1, extractions of 1-4 and 1-5. We extract this 1-4 and 1-5, and then we give 2 implants, and then we put the restoration on that implant. Next is FPD using the adjacent tooth, and third option is that we extract only the 1-4 and we modify the 1-5, where we give a normal PFM crown or zirconia crown, and we place the implant here, and then we do the restoration there. So what is the comparative evaluation of treatment options of the various that we just discussed? Now in treatment option 1, where we extract 1 and 4, the main thing is that we sacrifice 1-5, whereas the cost will also increase and the time for the total treatment to complete will also be more. In treatment option 2, the cost will be less, the time will be less, but the pegs effect is of some uh, doubt that whether it will be able to support the restorations in the long run. In treatment option 3, where we extract only 1,4 and 1,5 is modified, this is the thing that can be considered seriously. Now, final treatment options. So, in option number 3, we extract 1,4 followed by immediate implant placement, preservation and modification of 1,5 to maintain tooth structure so that it can support a PFM crown. This is a conservative approach which give a which is considered due to the favorable occlusion which is present in the patient, as there is no parafunctional habit. And in this treatment option, we can also preserve a natural tooth and reduce the cost also. So we start the treatment. 1,4 is extracted and 1,5 is prepared. You can see clearly in this picture that 1,4 is extracted, 1,5 is prepared. Next, immediate implant is placed with healing abutment. The size of the implant was 3.75 into 10 millimeter. After implant placement, we do a CVCT to analyze the accurate placement of the implant. We can see that implant is properly placed. Palatal bone is engaged and implant is in proper place. Now, after healing, you can see that 1,5 there is a temporary restoration is placed, and in 1,4 normal healing has been achieved. This is a gingival height measurement. This is needed to select the appropriate abutment for this implant so that we get a good emergence profile. After measuring with this gingival height, we select an abutment which is 4.5 millimeter gingival height. 6 millimeter is the height of the abutment, which can be modified if required, and 4.5 millimeter is the diameter of the abutment. Here you see that implant uncovering surgery is undertaken. After implant surgery is taken, we place a impression coping for closed mouth impression technique. The abutment in the cast after the occlusal adjustment of the abutment to get the necessary occlusal clearance. The abutment is placed into the mouth and we can see that we have got a good occlusal clearance for the proper restoration to be placed on it. And here we place the restoration, final restoration in 1,4 and 1,5, and the restoration is good, as you can see in this picture. This is the intraoral picture with good aesthetic, and the patient is restored and now he can attend his wedding confidently. And this is the 1 year follow-up of this case. You can see that the implant is in proper shape even after 1 year. This is the IOP X-ray after 1 year, but it is more than now 3 years. The patient is good. The malformed root, which is in 1,5, which we preserved, that is also in a good shape. The restoration is placed and it is also in a good functional state. So what is the outcome of this case? That restoration achieved acceptable aesthetic integration. Patient reported satisfaction after more than 3 years of follow-up. Functional occlusion maintained without complication. So this is the outcome of this case. And if we summarize, so this is the summary that effective treatment begins with structured problem identification rather than immediate selection of treatment modality. That means we have to see the 360 angle of the problem, that how the patient need the cost, the time, that all can be considered when we select a treatment. Patient-related factors such as aesthetic expectations and time constraints can significantly influence clinical decision making. That means that even if a treatment is very good, you know that this is good, but we have to consider that whether the patient is able to take that, whether he can afford that, whether he can give the time, then only we can make that treatment, like GBR or some uh, surgeries, which may be very highly cost driven. But if the patient cannot afford, if the patient cannot give the time, then the treatment has to be little bit modified to suit both the patient and the clinical outcome. A conservative context-based approach, when feasible, may preserve tooth structure and maintain flexibility for future treatment option. In this case, even if the 1-5 fails, we can always place an implant there and make this patient smile for a long time. This academic version of this case has been present in the Indian Prosthodontic Society West Bengal Dental Journal, and I hope that you can take some message and give better patient care. Thank you.